That's fantastic. Okay. All right. Respiratory system. I'm going to assume that you know the anatomy of how all that works. It's not too difficult. Know the parts when air comes in, what it comes in contact with, where it ends up, all that good stuff. But what this slide points out is the difference between internal and external respiration. Make sure you understand the difference between those two. Internal, we're dealing with the cells and the mitochondria. When we talked about at the beginning, a couple chapters. Is that door locked? No. Whenever we talked about how cells work and we talked about the mitochondria and what goes on, we talked about the Krebs cycle and all of that. When oxygen is brought in to the mitochondria, first of all, what is it used for? Do you remember? What's the purpose of having oxygen at the cellular level? What is it used for? Okay, more specifically, what is its role? I mean, it has to do with ATP. It's the final what? That's right. It's the final electron acceptor in the electron transport chain. Good. So, when we're dealing with the role of oxygen there, and we know that during the Krebs cycle, CO2 is produced. We talked about that. That would be internal respiration once we get inside the cells. When we talk about external respiration, we're talking about everything that's happening at the big scale. Pulling in gas from the environment, oxygen in, carbon dioxide out, circulation of those gases through the body, that's all external respiration. Okay. Okay. You also see that the respiratory system has non-respiratory functions. It's not all about just bringing in oxygen and getting out CO2. There's acid-base balance that's very important. When we get into the acid-base chapter, you'll see that carbon dioxide, when you mix it in with some water, you can make carbonic acid. And carbonic acid will fall apart. We'll talk about that later. Point being is where there's CO2, generally there can be acidic environments. So one way to get induced acidosis and things like that is to hold in a bunch of carbon dioxide, and if a person is not eliminating enough carbon dioxide and it builds up, acid levels in turn will end up building up because that carbon dioxide will start forming carbonic acid. Okay, so water loss as we breathe in the respiratory system. As we breathe out, certainly water vapor is one of the things that we breathe out. So if we have excess water loss, we need to eliminate more water. One thing we can do is breathe more heavily, that kind of thing. That'll rid some water loss. Heat elimination, there's heat energy that's trapped inside those molecules. So as we rid some of this stuff and blow it out, some heat goes with it. Venous return, we know that based upon your previous anatomy studies, you should know the basic differences between veins and arteries. Arteries sort of have smooth muscle that's around them. They're pulsatile. There's a pulse that elastic. It expands and recoils and helps propagate like a wave of, which is that pulse that you feel that pushes blood through arteries. Veins, on the other hand, don't move blood as easily. They have to use differences in, well, for example, they use muscle contractions, right? And like in the legs, for example, you actually get better circulation moving around because the muscle contractions have to squeeze against those veins to help move the blood. There's little valves inside your veins to prevent backflow, that kind of thing. But also pressure differences. When you breathe, you change the volume of your thoracic cavity. And as you'll see here in a second with another slide, when you change the volume of something, you're going to end up changing its pressure, assuming everything else is held constant. So if you start changing volumes and pressures and you get a place where think of it like your fists together. If one of your fists applies more pressure than the other one does, like if this fist applies more pressure than this one, it's going to move this way, right? So what you'll see is there's pressure gradients that exist. It's sort of like diffusion. When you have areas of higher pressure, it's going to move towards areas of lower pressure, okay? So that's going to help venous return. If you can create like a situation up here that's lower pressure, then it's the higher pressure system already, like in the veins, for example, the leg, it makes it easier for that blood to move towards a low pressure. It's just a little bit of a difference, but it helps. Acid-base balance, I talked about that. Vocalizations, obviously. Force air past the vocal cords. You can't do that without the respiratory system. It defends against inhaled foreign matter. You got cilia, that kind of stuff. You'll also see that when we get into endocrinology and we start talking about hormones, there are some, at least one in particular that we'll talk about, that it doesn't get converted into an active form until it flows through the lungs and gets into the bloodstream that's in the pulmonary blood vessels. Okay, so it can actually convert enzymes and that kind of thing, hormones. Okay, this is the stuff that you should already know in terms of the anatomy. You should know the pharynx, you should know the larynx, you should know nasal passages, all that kind of stuff. I'm not going to lecture on that. Know that around your trachea, of course, is the cartilaginous rings that keep it from collapsing, so you don't have to worry about that. Realize that within the bronchioles here, what the bronchioles are the bronchi are the main tubes, the bifurcation coming off of the trachea. When those further split out, those are the bronchioles. And they actually have smooth muscle around them that can contract and constrict and cause that airway to get smaller, okay, which would make it harder to breathe and that kind of thing. It helps regulate that. It could also dilate it and open it up, like in a fight or flight type of response. When you get sympathetic stimulation, you'll find that those bronchioles expand and open and allow more air to move in and out through those areas. Okay, this is stuff you should already know. So just keep in mind that we've got alveolar sacs at the end, the tips of those bronchi. We're going to look cellularly at what is happening at the alveoli, how the gases move across it. Why do we have, again, like a big bunch of grapes down here, right? A whole bunch of these little alveolar sacs. Why do we have that as opposed to just one giant sphere or one giant sac hanging right there? Why would we want the multiple? Why would we want alveoli? What does that do for us? It increases something. Surface area. It increases surface area. It gives us more membrane for diffusion to come across on. Okay, if you took all of these and separated them out, like for example, if you took grapes and you had a whole big bundle of grapes and you tore the skin off of each individual grape and you laid it out and measured up how much space it took up, and if you just had one giant grape that was the size of the entire thing and took its skin off, you would actually see that there's much more skin with a whole bunch of little grapes all stuck together when you spread it out. Okay, it's sort of the same principle here. We can cram more surface area, more space into a smaller area. Okay, now let's look at the alveoli. What we're looking at here, if you go back, take a look. This is not a clear picture up here, but what you have are you've got arteriolar region in terms of capillaries. You've got oxygen-rich capillaries, oxygen-poor capillaries here. That's the blue and the red. Notice how they completely cover and smother these alveolar sacs, because of utmost importance is letting these capillaries get close enough to these alveolar sacs so that gases can cross back and forth between them. All right, if we take a closer look, we're looking at one single alveolus with maybe one or two capillaries that are right next to it. In reality, it would sort of be covered around, and that would be all around it. Okay, but if you take a look at this, you'll see that they are very, very close to one another in terms of proximity. Those capillaries are right there, and there's actually sort of like a little fluid, some interstitial fluid that sort of kind of holds it all together. Okay, they're sort of joined in that respect. But they are separate structures. You will see here that here's a border of a cell. See that little line right there? As it comes around this way, here's the nucleus, here's another border up here. So there's a few cells that would sort of like a blood vessel that would encapsulate three-dimensionally what this alveolus is. Next to it, you would see a capillary. Remember, those are single-celled walls. They're not very thick either. But also what I want to point out is within this, these cells here are called type 1 alveolar cells. Those are the cells that actually make the alveoli. Now, within those, you see that blue one up there, sort of wedged in there and stuck in there with them, is what's called a type 2 alveolar cell. And I'm going to discuss what they do here a little bit. They secrete something. They secrete something called a pulmonary surfactant. Okay? A surfactant is actually sort of like a soap, okay, like a detergent. The way that soap works, there's one way, I guess, that it works, is it allows water to be wetter. Now, what does that mean? You can spread the water molecules farther apart from one another. If you're washing dishes, okay, assuming some of you wash your dishes, if you wash dishes and you rinse it out, right? You do the wash, you rinse it out, you dump everything out, and you have this cup. And at the bottom of the cup, you look down and you see little water drops in there. If you ever tried to shake that water out, sometimes it just never comes out. It's stuck on the bottom. There's always those drops that are always just too stubborn to move. granted, you could get them out if you really wanted to, but you see my point. There's always some stuck left in there. Water is a very cohesive substance. It likes to stick to itself very well. Okay. One thing that you do when you use soap on something is you cause water molecules that are normally attracted very much to each other to relax that a little bit and become less attracted to each other and spread out more over their surface. That's one thing that soap does. So that's why I say it makes water wetter, because wetness means it's covered with water and water goes everywhere. So to make water wetter, you would spread out those attractions between neighboring water molecules and get them to spread out more, get down into places, that kind of thing. That's one thing soap does. The other thing we'll learn about if you take chemistry or micro or something like that. We'll just skip the rest of it for now. So in this case, what you're going to see is, later on, this pulmonary surfactant is going to be very important because it's going to help break surface tension in water. And I'll explain why that applies in here and why that's so important. Okay, also, we mentioned these, I mentioned it briefly anyways. I didn't have you remember it, I don't think. But in terms of immunity, when we talked about the immune system, there are macrophages, and they're actually called, there's some called alveolar macrophages that reside and hang around in these alveoli for immune purposes. Okay, so it's general immune type of situations. So that's what this other one is right here. Okay, again, type 1, type 2. Type 1 makes the alveolus. Type 2 is a specialized cell within that alveolus that will secrete what's called pulmonary surfactant. Okay, okay, so stuff can diffuse across right here, in and out of these alveolar sacs into the capillaries, especially gases. That's what we care about, CO2, O2, that kind of thing. All right, make sure there's nothing on here. I'll talk about it later. All right, now, you know where the lungs are, I hope. You know, the thoracic cavity, all that jazz, so we're going to skip over that. But sort of in terms of what houses it, the ribs and all that kind of thing. Realize there is a pleural cavity around your lungs. Okay, there's a little tiny, very, very thin membranous sac that it goes around the lungs. It's used mostly, the fluid in there is for lubrication purposes mostly, because when you get expansion and relaxation, the inner layer is going to, if there was no fluid in there, would rub against the outer layer and create friction. You've heard of pleurisy before, and that kind of thing. That's what we're talking about in those types of conditions. There's wet and dry, and one depends upon, you know, whether there's a low amount of fluid in there and you get friction, or whether there's too much and you get like inflammation and swelling and that kind of thing. It just depends on the situation. But nonetheless, that pleural fluid is important, and that pleural cavity is important. And also in terms of pressures, and we'll talk about that here in a second. But so there's the picture. I guess you were unable to picture that in your head, and they had to use a lollipop and a water-filled balloon to illustrate this example. But I'm sure that you can understand what I'm talking about. Okay, realize where the diaphragm muscle is. It's like an upside-down bowl, right, that runs right along through here. Imagine how it contracts. It's sort of like if you got like a contact lens and you push it down and flatten it out. That's what happens when it contracts. So when the diaphragm contracts, it actually lowers. And when it lowers, it creates more space in the thoracic cavity. Okay, and I'm going to explain the importance of that here in a second. Okay, so we've got the diaphragm, we've got the pleural sac right here around the outside. That's obviously exaggerated. It's not that big in real life, but you get the point. Okay. All right. Now, here's where we get into little thought processes here. Some differences in pressure. See, this is the thing, too, people don't really stop and think about, is you do not have, when you breathe, you don't suck in air. There is no force that you create that just, you know, a force of sucking that comes in and you physically draw in that air. It's actually kind of weird how it works. The same way sort of a vacuum cleaner works. There is no suction force that exists in the universe. So how then, whenever you take a vacuum cleaner and you run it over a piece of dirt on the carpet, how does it just go into the vacuum cleaner? What you do is, through the motor and the spinning, you create such a low pressure system inside the vacuum cleaner that it's the pressure outside, okay, the pressure that's outside in the environment, outside of this vacuum cleaner, is so high compared to the pressure that's inside. I go back to this fist thing. Things are going to move from a high pressure to a low pressure. So it's almost as if the molecules that are in the environment that are outside this vacuum cleaner, they just diffuse. They jump right in because there's so much pressure forcing them there's so much pressure out here versus what's inside this vacuum cleaner, they just shoot right in the vacuum cleaner. There's no suction force. That's a natural force, a movement of high pressure to low pressure. So these gaseous molecules, this air as they are moving in, when a whole lot of it moves, it's sort of like when you throw something in the river. That thing itself is not moving. It's only moving because all the water molecules are carrying it, right? Same thing with dirt and dust. It gets suspended in these gas molecules that are in there, and as all those gas molecules start rushing in, so does anything trapped in them. That's why some things you can vacuum up, some things you can't. Some things might just be too heavy and that kind of stuff. So the lungs work in a similar way, although with nowhere near the vacuum force. That would make life interesting. But instead, what you do is you increase the size of your thoracic cavity just enough to alleviate some of the pressure that's in there. We all know that, right? If you increase the volume of something, you alleviate the pressure of it. So by alleviating a little bit of that pressure, you drop the internal thoracic cavity, everything in here, inside your lungs, okay? You drop that pressure a little bit below what's out here, so air comes rushing in. It goes in. And then when you exhale, you've got centers in your brain, we'll talk about, that cause these muscles to now relax, especially the diaphragm. That's what's most important in this. When that diaphragm muscle relaxes, it compresses that thoracic cavity. The pressure becomes greater than what's out here, so which way does the air go? Out. Okay? So all you're doing is contracting muscles, changing the volume of your thoracic cavity, thereby changing the pressure, and that's what moves air in and out. It's kind of a weird situation if you really think about it. It's not like you can just, it's not a suction force. How did I do that just now? I contracted a whole lot of muscles, very drastically changed the pressure, and you could actually hear it as it whistled by and went in. But there's no actual little contraption I have. There's no force in me that creates the sucking force. I just create a pressure difference, and then the air travels accordingly. Okay. And these pressure differences are what drive everything, not just biology. Weather patterns, climate, high pressure, low pressure systems. They come in, high pressure systems can move underneath and shift stuff up, and then you create movement of gases, which is air currents and all that kind of stuff. So this is what drives all of that. Okay, so as far as what pressures are there, let me introduce something here. The guy doesn't give credit on this slide, but the guy who sort of experimented all with this what's called atmospheric pressure. Like we use a barometer, right? You hear Kevin or Jesse, whoever you watch, if you want to watch Channel 2. You get to, you see these numbers all the time. What do they all mean? Evangelista Torricelli was an Italian chemist physicist who came up with this idea that mercury was great because mercury is the only metal that is liquid at room temperature. So given that, if you took a bowl of mercury and you had a tube that you inverted on this bowl of mercury, but the tube wasn't filled with gas, you figured out a way to create a vacuum. A vacuum is an area of extremely low or no pressure at all. Okay? So by creating a vacuum, in other words, removing anything that was in there, taking up space. So actually the tube is empty now. When you use a vacuum cleaner, you create a vacuum. You create maybe not a lack of any pressure at all, but at least an extremely low amount of pressure. So that's why it's called a vacuum. So if you create a vacuum in that tube, you've got no opposing pressure that's inside that tube pushing down inside that tube. What you do have is in the environment all the way around atmospheric pressure. You've got pressure from the gases in our environment exerting a force down, sort of like in a pool. You put your head this far underneath the pool, you don't feel much. You go down farther and farther, go 12 feet, 15 feet deep, all of a sudden it feels like there's a lot more pressure on you. The more actual molecules that sit on top of your head, the more pressure you feel. All right? Same thing as with atmospheric pressure. You've got gas molecules out here. The higher you go, the less of it you feel. The farther down you go, the more of it you feel. Okay? So he's saying that there was atmospheric pressure coming in and pushing down on this mercury. If you push down on the mercury, guess where it goes? Look at the diagram. Where do you think it would go? Up. It would go up this tube, right? Same thing like in your, go to a restaurant and you have a little straw and you put it in the drink. You'll see that for reasons more than just this, I talk about this in chemistry, but you'll see that you can get the pop to rise up through the straw some. Okay? If you can create a situation where there's more pressure outside than inside, that kind of situation, you can get it to rise. Well, what he did was he took a tube and he marked it in millimeters. So if you use a sphygmomanometer, a blood pressure cuff, if you ever look at the units, like 120/80, that's actually in millimeters of mercury. Okay, that's the unit that you use. It's in reference to this. He's saying that at normal pressure, at sea level, so say we're sitting right where we are right now, what you will usually find at normal pressure at sea level, you would find that there is enough pressure in the atmosphere to push down on a bowl of mercury to make it rise at 760 millimeters up out of that bowl. So that's called atmospheric pressure. We also, in chemistry, we call this 1 atm, 1 atmosphere, which is the same thing as 760 millimeters of mercury. Okay, so in this case, what you see on a barometer measures this pressure just like this, atmospheric pressure. But you see readings like 28, 29, 30, 31, that kind of stuff, because that is millimeters that has been converted into inches. Okay, so when you see like 29 on the barometer and it's rising, that means right now it's at 29 inches and still going up, as opposed to, so typically it stays within that 28 to 31 region in terms of inches. But here, this is in millimeters. So, all right. So I'm going to use the pressures of millimeters of mercury is what I'm going to use to talk about as we go through here. All right. So atmospheric pressure outside of our lungs. Let's say it's around 760 millimeters of mercury. That's the pressure. So that would come in. When it comes in our lung, we're going to have an intra-alveolar pressure. Okay. So that's going to be whatever pressure we're talking about that's inside the alveoli pushing against the walls of the alveoli. Then we've got an intrapleural pressure. We've got a separate pressure because there's boundaries here. We've got a separate pressure that's just associated with this blue region, which is the pleural cavity. Okay. What you'll notice up here is that that pressure is slightly less than atmospheric pressure, assuming that this comes in and as this diffuses in, this pressure increases. The point is, this is usually always about 4 millimeters of mercury less than what you're going to have in here. Now, why is that necessary? So that the lungs can expand. Okay? If this pressure right here was maintained at 760 or greater, you wouldn't be able to get lung expansion. There would be too much force. As the lung was against it, trying to push out and expand, there would be too much force holding it in place and wouldn't allow your lungs to fill up. Okay? So that's why there's got to be a little lower pressure right there. Your lungs don't expand indefinitely because, number one, we have body that holds it. The forces of our just structural body holds it in place, doesn't let it expand past a certain degree. But also the cells that make up the alveoli in the lungs are only able to be stretched so far, and then they recoil back. Okay? All right. Now, what happens if you get stabbed in the lung? Because that happens so frequently. What happens if you get stabbed in the lung? Or just, something happens to where you poke a hole in the lung. We've got what's called a pneumothorax. Okay? In this situation, notice what will happen. The problem that we're going to run into here is the pressures are going to get screwed up. If the pressures get screwed up, things aren't going to be able to move like they're supposed to. For example, if there is a breach in this wall right here, here's a puncture wound in the chest wall. It doesn't matter, let's say it goes here, it goes all the way through. Chances are if you get a puncture wound in the chest wall, it's not just going to nick your pleural cavity. That is so small and so tiny, you're going to get a hole in the entire lung is what's going to happen. So it shows it right there, but realize it's pretty much the same as if it went all the way through here. Now, what does that mean? That means that now there's a hole here, and this was at 756 millimeters of mercury. What's going to happen? What's going to happen is air is going to move in, right, from the outside. It's going to move from a place of higher pressure to a place of lower pressure. When it does, it's going to move in, and it's going to keep filling up this area and keep pushing it until you get a situation that looks like that. You've got 760 millimeters of pressure coming in from the atmosphere, but at the same time, you've got that same amount coming in from the atmosphere on this side. So they meet each other, and they balance it out, and you get no lung expansion, no lung recoil. You get non-function is what you get. It's not allowed. The pressure is now set up to the point where you can't get that to work. All right. Make sure there's nothing on that previous slide. All right. Now, what if you get, let's say that you just hurt the inside of the lung, like a spontaneous pneumothorax. A good example of this is like emphysema, or you damage your alveoli and they start to pop, and an opening, like some of the alveolar sacs are destroyed and now they're open to the pleural cavity, something like that. What could happen there? Worst case scenario. Well, you don't get a puncture from the outside, so you don't have to worry about the equilibrium setting up. You don't have to worry about the gases trying to come in and balance themselves out from the outside. But what you do have to, what you will get is, this is a different clicker. I'm not used to this one. What you will get is, as the air comes in here, instead of filling up to a certain degree and then stopping, it's going to sort of leak out and fill all the way around, and it's going to make that 760 all the way around, and eventually you're going to be back to right where you started, and it's going to look like that again. Okay, so it's very important that we don't breach this containment that we have here in terms of pressures. We need them to be differences in inside and outside. I just thought I found some cool pictures, so I threw them in. In this case, if you were looking at collapsed lung, how would you know? I know we're not trained in radiology or anything, but this is kind of neat. You could see here on this side, on the left lung here, see all these vascular, looks like fibers kind of sticking through there, sort of a whitish color, kind of all spread out. That's indicative of vasculature that's going through and separating out through all the alveoli and that kind of thing. So you see what's called hyperlucency right here. You can see through it really easily. See how much darker that is, and it's you see straight from front to back as opposed to how easily you can see over here. Not as easily over here. And absent vascular markings. You don't see all this fibrous-looking stuff like you see over here, because what has happened is all shrunk down and it's right around in here. You see this little more dense area right here. So that would be an X-ray of like a collapsed lung in that particular person. Okay. Now, like I say, normally we get a stretching of the lungs during an inhalation. Now, part of the reason, too, what else is happening is we've got pressure coming in from the environment, pushing against the walls of the alveoli that is going to cause total lung expansion, because all the individual alveoli can expand a little bit, so the whole lung expands. Also, coupled in with this, and see if you can grasp this or not, I don't know, but at the same time this is happening, what we have is around the outside of the lung we have that pleural cavity. Okay? Now, inside that pleural cavity is a fluid, and that fluid is very cohesive. So what that means is all the molecules that make up that fluid, they like to gravitate towards one another. They like to be attracted to each other. So as this lung is expanding, realize that at the same time, I need an animation to show you this, but at the same time that the alveoli are pushing against that because of the pressure differences, the fluid within that pleural cavity is also attracting to itself. It's sort of constricting and pulling up at the same time. So it's sort of like it's pulling it out. It's like grabbing it and helping pull it out. Does that make sense? Can you grasp that or not? I don't know. I don't know what a good analogy would be. I don't know. Let's just see if I can go with it here in a second. But so you've got the pleural cavity that's outside of the lungs. There's fluid in it. The fluid attracts itself. Now what you got to realize is, as the fluid is attracting to itself, that's happening all the way around the lungs, not just in one place. So that means the whole thing is sort of trying to shrink, but not collapse in on itself. It's trying to spread out. And when it does that, coupled with the difference in pressure, it causes the lung to expand. Now, if you look, it talks about intrapleural, transmural pressure, pushes lungs outward, that kind of thing. Let me show you what I'm talking about. Here's a label of the different pressures going on. We've got atmospheric pressure coming in, and then it sort of balances itself out until it's about 760 on the inside as well. Diffusion, right? Things are going to continue to diffuse until it sort of equals itself out. Same thing with gases. So we know that this pleural cavity here is always about 4 less to allow that pushing to occur. And when it expands out, realize that this is called it says right here, transmural pressure gradient. This is the difference between what's going on in here and what's going on in here. That's the gradient. Like listed as of now, the gradient's about -4. That's what we were talking about. Now this outside wall of the outside cavity, that's anchored to your body. That's anchored to the inside of your body. That's not going to move. That doesn't allow for expansion and that kind of thing. So that's what I was talking about a while ago. You can't just expand indefinitely. All right. Now, I was talking a minute ago about how when you change the volume, you can change the pressure of something. It's just like us. You give us, if I confine you all to chairs all next to each other, that would be sort of like a high-pressure situation. But if I allow you to spread out, if I give you more room, you still have the same number of people present, but everyone's a little more satisfied. They're not all up in everybody else's business. Everyone's spread out just a little bit. Molecules like the same thing. Take a look at this. Let's say I start with this right here as my volume. I've got a container, I've got a piston, and I've got gas molecules in here of a certain number. That doesn't matter. I've got a certain number of them. I've got a piston pushed down on it, and I've got a pressure gauge measuring how much pressure I am forcing down on these. Okay. Now, if I take that piston and I pull it out, and I make the volume twice as big as what it is now. So however far this distance is from here to here, I do the same thing. I move it up to here. Okay, so same distance, pull it up. When I do that, I've doubled the volume. What have I done to the pressure, do you think? Has the pressure went up or has the pressure went down? Has it gone? It'll have gone down. Not only has it gone down, it'll go down by the same factor by which your volume went up. So if I increased my pressure by 1 unit, I'm going to have, if I've decreased my pressure by 1 unit, I'm going to have increased my volume by that same amount of units. Okay? So in terms of equalness, they're equal in terms of value, but they're in opposite directions. As pressure increases, as volume increases, pressure decreases. As volume decreases, pressure increases. Okay? Take a look at these pistons, you'll see what I mean. I can go even further. I can double the volume, and I still have the same amount of molecules present. I double the volume. I've got even less pressure now. Okay? So this is called Boyle's law. In chemistry, we look at equations to predict all this stuff and how these play out in chemical reactions. But it's called Boyle's law. We're assuming that the temperature doesn't change. We're just sitting here experiencing whatever temperature. But we are changing. So in the case of our lungs, what we're doing is what you see here. We are taking our thoracic cavity. We are contracting our diaphragm muscle. We can even contract some intercostal muscles between our ribs that when they pull our chest up a little bit to give us more space. When that happens, you see what's here. All this opens up. So what happens to the pressure? It decreases. You can see that there's a lot more space between them. The pressure has been alleviated. So what happens to the air from the environment? It wants to go in. It's a lower pressure system. Okay? All right. So here is some anatomy like I just said in terms of what controls these contractions. What controls the inspiration, that kind of thing. Inspiration, the most important thing is the diaphragm muscle, which is innervated by the phrenic nerve. The diaphragm is not shown here, but the outline of it is. It's inside the rib. You can't really, inside the ribs there, you can't see it, but there's the dotted line for it. Inverted bowl, sort of. Okay, also, another thing that's very important is what's called the external intercostal muscles. Okay, you see these right here. The external intercostal muscles are the ones towards the back right here that are between all of your ribs. When they contract, they pull your rib cage open is what they do. And when they pull open, that gives you more space. So it drops down here, it pulls open up here, you get more volume, thus less pressure. And that's what's going to cause the air to rush in. Okay, so like I said, diaphragm is the most important. Actually, 75% of this enlargement that we see is because of the diaphragm itself. So, all right. Now, you also have what's called accessory inspiratory muscles. Those are when you're taking those really deep breaths and you're trying to suck in even more than what you normally would. You can use your sternocleidomastoids, which are the ones that sort of turn your neck. You could actually contract those both together, though, and pull this up even more. You can use, what does that say? The scalenus. I don't even, the whole muscle thing. I'm a chemistry guy. I'm physiology. But you can contract inspiratory muscles even further to pull up even farther and get a little bit more volume, and thus decrease the pressure just a little bit more for those deeper breaths. Okay. All right. Now, as far as expiration, what you've got to realize is that they're dueling each other. There are control centers in the brain that are telling muscles to contract, to inspire. At the same time, there's messages being shot to expire. They have to counter each other, and there's a cycle that this goes through. So the diaphragm relaxes. Not only that, it's sort of like you've taken a rubber band and stretched it. It naturally wants to flip back. The alveoli do the same thing. Whenever the diaphragm relaxes, it closes up and creates a higher pressure, wanting to force the air out. But also what helps in addition to that is the fact that the alveoli that have now been stretched throughout the lung have a natural recoil to them that they want to snap back. So that works in conjunction with the decreased pressure. All of that drives the air out of the body. Okay. Now, again, just like with forced inspiration, you can have a forced expiration. You can force more air out of your body than you normally would. The biggest contraction you're going to have there is with your abdominal muscles, if you've not experienced that before. Contract them as hard as you can. You can force more air out. It kind of just pulls everything back a little bit and decreases a little bit more of the volume, and thus increasing the pressure. Okay. I think this is, I don't know, we need to go through this. It's just showing you that, obviously, as you are expanding, you're decreasing the pressure. And if you can drop it even as low as 759, that's still less than atmospheric pressure. So once you start dropping it, this air is going to start leaking in. The more you drop it, the faster the air is going to come in. And the opposite is true as well. Once you can overcome atmospheric pressure on the inside, you can force it out. The higher you can get, the greater the difference you can create, the faster you're going to force it out. Okay, airway resistance. This should be self-explanatory. You know that normally things flow, and they don't flow as good whenever there's something blocking its path. That's basically what this says. It just uses fancy words to say it. It talks about the word resistance, and you'll see the word inversely proportional. What that means is when one increases, the other one decreases by the same factor if they're inversely proportional. Sort of like pressure and volume, what we just talked about with Boyle's law. Pressure and volume are inversely proportional. When volume goes up, pressure goes down. In this case, when resistance goes up, flow goes down. Okay? If resistance goes down, flow goes up. You increase your flow of air in this case through the tubules, through the bronchioles, that kind of thing. Okay, now the major determinant of resistance is not just blockage in this case. Perhaps with cardiovascular situations, we've got occlusion, we've got atherosclerosis, those kinds of issues. When you get into the respiratory, there's not as much of that, but what you do have are the smooth muscle that goes around the bronchioles can constrict and go into spasms. And when that happens, you get a narrowing of that bronchiole, and it gets down and constricts itself, and that's resistance. It increases resistance. It's sort of like trying to drink your coffee through an actual straw versus one of those little stir sticks. Because it's obviously the smaller the radius, it's like your head explodes. But the smaller the radius, obviously, the more resistance you're going to get. So, okay, I mentioned here airway resistance is increased abnormally with what's COPD, chronic obstructive pulmonary disease. That's sort of a general kind of thing. It's not like it's just one specific disease. There's a lot of things. It's a set of situations, or a circumstance that you find yourself in that could be due to a myriad of reasons. It could be asthma, it could be chronic smoking, it could be a lot of other things, infection, that would create a situation that is not going away in that person. It is chronic, and it's something that's causing an obstruction in their airways. So that's COPD. When you have patients like this, typically what you struggle with more is with expiration as opposed to inspiration. But all right, asthma is the obstruction due to inflammation. What happens is, and I'll mention this a little bit more later, but mostly it has to do with constriction. These airways start to constrict, and the reason they constrict is almost like some sort of allergic response. It's not really an allergy. There's allergy-induced asthma, but mostly what could happen is there's some sort of response that would trigger some sort of bodily immune response or whatever in this particular person. It would cause the airways to constrict. It could be just that it's not an immune response. It could be just a natural overexcitation of that smooth muscle in the bronchial tubes. And when that happens, obviously it becomes very, very difficult to breathe. Resistance increases big time, so flow decreases as well. Emphysema is when your alveoli actually start to collapse. It's almost like if you had all these grapes on a bunch. Is that what they're called? A bunch? Is there a term that describes this cluster? I don't know. But say you have this thing of grapes, and you could pop them like with a pin, like they were bubbles. What emphysema is like if you take those grapes and start popping them. And instead they sort of pop from the inside, but their outsides sort of all meld together, and you could turn like a big cluster or a bunch of grapes into like one giant grape. So you're drastically reducing your surface area when you do that. That's basically what emphysema does. It sort of destroys these alveoli and decreases your surface area in the lungs. They start to collapse. So what you see is sort of this. And this person, emphysema destruction happened up here. You can see this hyperlucency, how clear it is up here. This picture doesn't show it near as well. If you look online, it's kind of blurry up here. But you could actually see in a normal person, there was a little bit more faint, fibrous-looking stuff up here where these alveoli, blood vessels were. Oops. Up through here. In a person with emphysema, you're losing that. Because as those alveoli start to pop, a lot of them tend to die as a result, and you're going to lose lung function. When things start to die, blood vessels don't feed them anymore. So you can get areas like this where that vasculature is not there anymore. All right. Now, asthma, like I said, you've got profound constriction of these airways. Excuse me. There's some sort of allergy-induced spasm, in other words, constriction of those muscles. And then another thing that tends to happen is the body's normal response is there's some sort of irritant, there's some sort of a thing that I should do to attack what's going on, so I start producing more mucus. You could get white blood cells to start coming in. When you start getting white blood cells and antibodies and that kind of stuff to come in, you start getting edema. You can get swelling in the tissue and that kind of stuff, which all just exacerbates the situation. It just makes it even worse than what it already is, and everything constricts even further. So anyways, I got a link here that's a pretty good website. If you have asthma or your children do, or you know somebody that does, you may want to check that out. There's a lot of information on there. So, okay, now the lungs are elastic, mostly because the alveoli are elastic. They can stretch, and when they stretch, they want to recoil. Now, this brings in a word called compliance. Compliance is how easily it can be stretched. It's sort of like if you take a normal balloon that you use to blow up something versus like a water balloon. Have you ever tried to blow up a water balloon? Like they're much more sturdy. It's hard to get them to expand. We would say that a toy balloon, a regular balloon, is much more compliant than like a thick, rubbery water balloon. So that if it's easier to descend and come back, then it's more compliant. And what you'll see is with disease, if things start getting destroyed, if you start losing alveoli through emphysema, or you have COPD, or you have diseases that are going to affect the membranes of the cells involved, obviously you're going to reduce compliance. You're going to make that lung to where it's not be able to stretch and recoil near as efficiently as it once could. It's like a rubber band. Think of that. You have these nice, new, fresh rubber bands that you can stretch out and they snap back, and then you got those old, nasty, broken, cracked rubber bands that are like almost hard, and you try to pull them and sometimes they even break. Yeah. Think of that in terms of lungs. You got those old, nasty, gross lungs. Not necessarily old, but you know they look as if they're old because they've not been taken care of. That kind of thing. You lose compliance when that happens. So, okay. Now, I talked about alveolar surface tension. Let me see if this is on my next. Yeah. Okay. On this one right here, it says the pulmonary elastic behavior depends upon alveolar surface tension. Now, what that means is there's going to be an attraction between the water molecules that are inside the alveoli. Now, this could be a problem. If you take a look, I'm going to come back to that screen in a second, but take a look. I'm inside an alveolus now, an individual one of these. And because of the way it's designed, I mean, there's fluid filled, there's a lot of empty space inside for all these gases to come in, but around the edge, especially where the membranes of the cells are and that kind of thing, you've got these water molecules that are part of the matrix here that we're dealing with. And water molecules really like to attract to themselves, and this is a very small area. So what will tend to happen is, if these were, obviously this is grossly exaggerated, but if these were water molecules, they would all be attracted to each other, and not only side to side, but notice where the arrows go towards the middle. The ones over here would be chemically attracted to the ones over here, and they would start to come together. So what does that mean for the alveolus? Collapsing. Okay? This is a very small space. Unlike the big pleural cavity that we've been talking about, there was a big separation between them. This is microscopic even sometimes. We're down really, really small here. And it's very, very thin. It's only one cell thick, right? This alveolus. So I mentioned a while ago those type 2 alveolar cells, they produce pulmonary surfactant. This is why it's going to be so important. What we have to do is make sure we're able to break this surface tension to keep these waters spread apart from one another so that they don't collapse and you don't get alveolar collapse and thus cessation of respiration. This can happen sometimes in babies. It's called respiratory distress syndrome. They have a genetic problem whereby they do not produce pulmonary surfactant like they should. The proteins that are involved in the formation of pulmonary surfactant are genetically mutated or lacking or whatever. And if that's the case, respiration is a big issue. You can test for that and you can monitor that. But let's go back a couple. I think that's it. Okay. Now, for any of those of you who, and I say this not to be a smart aleck, because it's just because I have this every semester. It happens to somebody every semester. For those of you who make the choice to no longer be in the nursing program and instead go towards respiratory care, because it always happens, this will be of particular importance to you because this will be beat over your head and shoved down your throat always and again and over. So we'll talk a little bit about some of these things up here you see that has to do with respiration, levels, terminology, that kind of stuff. Normally, when you breathe in and out, on average, at least this average based upon, normal young white male, whatever, how all that works. It's just an average. Somewhere around 500 milliliters of air are what you move in and then move back out. We call that a tidal volume. Tides kind of come in, they ebb and they flow, that kind of thing. So the tidal volume is somewhere around 500 milliliters for an average person. But again, big window there. All right, now what does all this graph mean? I'm going to spend some time just looking at this. We used to do a respiration lab. I don't think we'll have time for it this semester where we measure all of these. But you've probably seen them if you work in these places. You've seen the spirometer, whether it's wet or dry, probably wet. I mean, if the test that they're doing, people breathe in them. They measure stuff based upon how much stuff gets displaced and all kinds of stuff. They do breathing tests on that to determine how well the lungs are functioning. Well, how does all that work? How can you just tell that from a machine and how much you can breathe? We'll take a look and we'll see what that means. This TV right here, I don't know. It's not very clear up here. I don't know how clear it is in your notes, but this says TV, and what it represents is a normal inhalation and a normal exhalation. TV stands for tidal volume. It's what you normally just breathe in and then breathe back out. And if you measure that amount of air, so going up, breathe in, breathe back out, the total volume underneath that right there is around 500 milliliters for the normal person. All right, so what do the rest of these mean? If you look right here, next to that, you see letter IRV. IRV stands for inspiratory reserve volume. They don't really call it IRV, so don't go around saying that. It sounds stupid. I just say that. So, the IRV is the inspiratory reserve volume. Basically what that means is reserve is what's left over, right? That means the inspiratory reserve volume represents all of the amount of air that you could have inhaled, but you didn't. Basically, that's what it says. It's everything above, up to the limit. It's everything above your tidal volume that you had room for that you didn't inhale with that breath. Okay? Now, what is that? What is well, how much can you hold in a person? Notice up here, your total lung capacity. Now, this is not inspiratory reserve. This is if I had some sort of compressor and I just blew it into your lungs and I could fill it up as much as I could before they popped, how much could they hold kind of thing. If they treating them as just a big sack of air, how much air could I get in there? For males, it's typically about 5.7 liters, okay, about 5,700 milliliters. For females, typically the average is considerably less, actually, 4,200 milliliters, about 4.2 liters. So there's actually over a liter difference on average. Okay, and then whenever you compress, how much usually stays in after you breathe out? About 2,200 to 2,700 milliliters on average. After you've forced out everything you possibly can and you cannot force out any more, how much can be left? Typically, there exists an amount that no matter how hard you try, you're never going to get rid of. About, normally around 1,200 milliliters or so. So anyway, to name all these things, tidal volume, what you normally breathe in, normally breathe out. Inspiratory reserve volume, how much more you could have with maximal inhalation pulled in your body. IC stands for inspiratory capacity. Okay, that is basically your inspiratory reserve, how much you didn't that you could have, added together with your tidal volume, which you did. So put those two together, add them together, and you get what's called your inspiratory capacity. That's how much you can total bring in when you inhale. Okay, so another way to look at it, your inspiratory capacity is the sum of your tidal volume and your inspiratory reserve added together. All right, now what's the next thing? It says ERV. That stands for expiratory reserve volume. Notice you breathe in, breathe out. That's a Bush song, isn't it? Breathe in, breathe out. Breathe. Machine Head, that's that song. Anyways, breathe in, breathe out. Breathe in, breathe out. Breathe in as much as you can. Breathe out. But instead of going, that's too far. What this represents is just normal exhalation then, getting rid of all of that. Okay? Now, once I got to there and then I went and tried to blow everything out, I'm down in here. That's the expiratory reserve volume. That's the amount that I had left that I could force out if I needed to, but I didn't on a normal breath. Okay? So that's the expiratory reserve. It's the sound effects that make this, I'm telling you. All right, now, the reserve volume is, no matter how hard I try, blue in the face, pass out, I'm not going to be able to get it out of my body. Okay, there's a reserve volume there. Okay, that would be like this up here. All right, now, the FRC stands for functional reserve capacity. Is that even on there? Oh yeah, there it is. Functional, they call it residual. It's the same difference. Functional reserve, functional residual capacity. This is basically just sort of like your inspiratory capacity, right? Over here, this is how much you actually breathe out plus what was left that you can't breathe out. Those two together collectively are called functional residual capacity. Okay. Now, your vital capacity. That represents a total intake as much as you can possibly intake, blowing it out as much as you can possibly blow out. That difference from top to bottom is called your vital capacity. Okay? That's taking the deepest breath you can and forcing out as much as you possibly can. However much volume of air is associated with that you've moved in and out. Okay? Underneath all of this, that's your vital capacity. That is probably that's the most important measurement. Okay? It tells us how compliant your lungs are going to be. Is that within normal range? Is something wrong with your lungs? Have the alveoli been destroyed? Is there a lack of compliance? And then you would start looking at, okay, if their vital capacity is low, is their inspiratory capacity high? Is it low? What about the expiratory? Are they both low? Is there a problem on one end or both ends or what? And then you can start looking at these values and get an idea as to what's wrong with that person in terms of their breathing. TLC stands for total lung capacity. That's how much you could fit in if you just blew air in or whatever. Notice that goes all the way up to the top, but also down here all the way at the bottom that we can't. That's our total range, basically. Okay, you will have to know these. You'll have to know what they mean. Okay? All right. Let's see. There's a spirometer, if you've not seen one before, but I just explained that whole slide already. So, all right. So pulmonary ventilation. Ventilation is how much you're going to move in and out of your body. Just total. That doesn't necessarily mean through your lungs, because what you got to realize is when you breathe in and you breathe out, you've got what's called anatomic dead space. You're going to have some air that stays in your mouth, some that stays in your nasal cavity, some that stays down here in your throat. So you know. That's gonna have an effect and everything in terms of all these values that we measure and that kind of thing. So to actually get pulmonary ventilation, ventilation is like a combination of not only how much you are moving, but how fast. How much and how fast. That's ventilation. So you would take your tidal volume, your normal breathing, times whatever your breaths per minute, whatever your respiratory rate is, multiply those two together, you've got a ventilation. Okay. Now, but realize, like I said, you've got alveolar, to calculate what's called alveolar ventilation, not total body ventilation, but just alveoli, you've got to subtract out any dead space that would occur, any place where air could get trapped, so that you could just focus on the alveoli. All right. Obviously, Your breathing pattern can affect how well you ventilate. If you breathe slow, heavy, and deep, you allow more time for gaseous exchange. You allow more oxygen to travel through. You increase that efficiency. You let more CO2 get caught, that kind of thing. All right. Oh, one thing to note here, this is kind of neat. What our body generally responds to more than anything else is carbon dioxide levels. What you will see is in the alveoli, if the carbon dioxide levels are increasing, there are chemoreceptors that will detect that. We have cells that can recognize as to whether or not these levels are too high. If, it says right here, an accumulation of carbon dioxide in the alveoli will trigger a response that decreases airway resistance by causing relaxation. In other words, it'll relax so that this can get pumped out, so that more flow can happen because it wants to get rid of that carbon dioxide. Okay. An increase of oxygen could cause pulmonary vasodilation. It causes vasoconstriction of pulmonary arterioles. The point is these gases can control. If they start getting built up, if there's a lack or there's an increased amount of either one of these gases, these airways can respond, and the alveolar sacs can respond as well to either increase or decrease the rates that are happening. Okay, partial pressures. We know that the two most important gases we're dealing with here are carbon dioxide and oxygen, and we also know that nitrogen is, for example, nitrogen is 79% of our air. Now, if we know that total atmospheric pressure is about 760 millimeters of mercury, and we know that 79% of all that's present is made of nitrogen, we can calculate what's called the partial pressure of nitrogen. Of that 760 millimeters of mercury, how much of that pressure is due to nitrogen alone? So you take 79% of 760, and you can get 600.4. That's called a partial pressure. So what we want to look at here is the partial pressures of oxygen and carbon dioxide outside the body versus inside the body. And then once inside the body, what's in the blood versus what's in the tissues. Because these partial pressures are what's going to drive the movement. Anywhere there's a higher partial pressure, it's going to move to where there's a lower partial pressure. Okay? So if you look up here, you can see that, okay, let's say PO2, it's not very clear up here, but say PO2, the partial pressure of oxygen is about 100 millimeters of mercury. Let's say the partial pressure of oxygen is 40 millimeters of mercury, let's just say. All right, so as that comes in, that's sort of like a concentration. That's how much pressure, that's how much oxygen is there when it comes into your lungs and meets up with the capillaries on your alveolar sacs. What you will see is your lungs then, having brought in, realize what your blood has been doing, right? It's been dumping off oxygen, it's been picking up carbon dioxide. When it makes its way back to the lungs, what you have here is that PO2, what does that say, 40? Can't really tell, it looks like 40. The partial pressure of oxygen has dropped to 40 because oxygen has left and went to the tissues. So naturally what happens then is the blood, as it travels up here into the lungs, into the alveoli, since the partial pressure of the atmosphere in terms of oxygen is greater than what's in the blood, oxygen comes diffusing in. And it crosses and goes into the blood. Carbon dioxide has actually increased its value because of it's produced during the citric acid cycle. It's produced during cellular respiration. So the partial pressure increases, and when it gets to the lungs, it wants to leave and go out. The total pressure is not what we're dealing with here. We're talking about the individual pressure of CO2. What about that individual molecule? Where will it want to go? It'll want to go from a place of higher pressure to lower pressure. That's what we're talking about here. All right. I think that's it. Okay. I think I just already covered all that. But, yeah, we can skip that. Now, one thing to realize about diffusion is the more surface area that you give diffusion, the faster it's going to happen. Okay, that's why these alveoli are so important. Give it more surface area, it's got more room to cross, the faster this diffusion is going to happen. So that's why I say up here, as surface area increases, the rate increases. If you have emphysema, like I said, you're going to get destruction of alveolar sacs, and you're going to slow diffusion. Breathing is going to be harder in terms of getting the gases where they need to be, that kind of thing. All right. Another thing that's going to affect the rate of gas transfer is, again, the biggest thing that's going to affect the rate of gas transfer is these partial pressures that we've been talking about. Is it higher over here, lower over here? It's going to move. But also, in addition to that, is what this is about. Surface area. Not only is there a pressure difference, but is there a lot of surface area over which this can occur? Secondly, how thick is the thing that they have to cross? If they got to diffuse from here to here and they got to cross a membrane to do that, the thinner the membrane, the faster it's going to happen. Okay? How does this play out in real life? I say here the walls of the alveoli and the pulmonary capillaries, they're very thin. They're 1 cell thick. If you have obstruction, if you have mucus, if you have pneumonia, you have any other bacterial infection, if you have pulmonary edema, anything that would cause the layers to be thicker for these molecules to have to cross, you're going to slow down diffusion. You're going to impede breathing. All right. It says also that gas exchange is also directly proportional to the diffusion coefficient for a gas. What does that mean? Directly proportional means when one goes up, the other one goes up. So what I'm saying is, with certain gases, we have in chemistry what's called a diffusion coefficient. How well it diffuses, just based upon its chemical properties. You will find that carbon dioxide, for example, dissolves in water much easier, stays in water much easier than oxygen does. So that means it's going to diffuse better in a water environment. That's going to add to its diffusion. Are certain molecules attracted more to themselves? If so, that's going to slow down diffusion. That all comes into one equation that we use to calculate what's called a diffusion coefficient. You don't have to do that. Just know that it exists. Okay. For example, the coefficient is 20 times as great for carbon dioxide as compared to oxygen. It's easier for carbon dioxide to diffuse based upon its chemical properties than it is for oxygen. All right. Let's see. Don't need to say anything about this. I think we already covered this. Yeah, we already covered this. Okay. Now, as far as the oxygen that is in the blood, how does it travel? We all know that it rides on hemoglobin, right? There's actually a very, very small percentage of oxygen that just gets dissolved as O2, oxygen gas floating around in the blood, but that's very, very small, only like 1.5%. Most of it is carried on hemoglobin, more specifically on the iron part. Hemoglobin is a large molecule with a whole bunch of atoms. One of the atoms involved in the formation of hemoglobin is iron. That's why it's so important, okay, for good blood circulation and all of that, is because iron actually is the binding site where oxygen can hook on to hemoglobin. So you have to have adequate iron, otherwise you've got dysfunctional hemoglobin. All right. Now, whenever oxygen binds to hemoglobin, we call it oxyhemoglobin. This is reversible, and when it reverses and it falls off, we call it deoxyhemoglobin. What you'll find is that hemoglobin likes to bond with oxygen when it's really cool, okay, in terms of temperature. So in the lungs, this is great. It works out for us because in the lungs, it's much cooler than it is way out here in the tissues. So up in the lungs, you get a good junction, a good coming together of hemoglobin and oxygen. And then as it warms up, as it goes throughout the body, it tends to dissociate a little bit better. Okay? You'll find the opposite is true for carbon dioxide. It tends to, under warmer temperatures, it tends to bond with hemoglobin a little bit better. Because, yeah, some carbon dioxide is carried on hemoglobin as well. And when it's cooler, it tends to fall off a little bit better. So that helps us. Okay, like I said, a very small percentage is actually dissolved in the plasma floating around. You don't want a bunch of gas floating around in your plasma. That ain't never good. All right. Now, you guys seen like the O2 sat levels and stuff. You put that little thing and you can see the 90. It never really gets higher than 98. You can't get 100% hemoglobin saturation. It's not possible. Typically, you're happy with around 98, 97.5, 98. What that means, what that is measuring is the degree to which your hemoglobin is saturated with oxygen. If that's really low, that means your hemoglobin is not carrying much oxygen. If it's around 98 or so, then that's carrying as much as it normally should. So what you see here is at a higher, what determines that? What determines your oxygen saturation is the partial pressures, okay, of the system involved. At a high pressure, if there's a place where there's a high pressure of oxygen, as long as your body is respiring normally and maintaining the proper level of partial pressure of oxygen inside your bloodstream, then it's enough to force, just by sheer presence and force of oxygen, force them onto that hemoglobin. So at high pressures over here, you get a high concentration, a high saturation of hemoglobin. So all the way up to like 98% saturated. Okay, of all the ones that are present, 98% of them are being used and taken up and holding oxygen. You'll find very drastically and very quickly that as these partial pressures change, as you lose respiration capacity, as your gases are not being delivered, this could be for a lot of reasons, right? It could be cardio reasons, it's not pumping properly. It could be respiratory reasons, it's not exchanging properly. Who knows what's going on here? But the point is, if something causes a lack of the partial pressure of oxygen or carbon dioxide present, in this case oxygen, once that partial pressure starts to drop, the saturation levels are going to drop proportionally. They're going to start dropping as well. So that's one thing you would want to measure. That's why those are always hooked up. You can monitor that and realize that. Okay, this is called the oxygen hemoglobin dissociation curve. If you see those words, that's what it means. Okay. Now, like I said, maximum is about 97.5% saturation, which rounds up to about 98. Generally what you see on the monitor. Like I said, at the tissue, this thing's going to fall apart. It's going to deliver its hemoglobin. The hemoglobin is going to deliver the oxygen rapidly. It can even help pick up carbon dioxide, although that's not mostly how carbon dioxide moves around. What will happen here, though, it says various factors promote the unloading. In other words, the oxygen unloading, dumping off to the tissues. You can increase in carbon dioxide from the tissue cells. If there's a control mechanism inherent to the tissue cells, if there's carbon dioxide accumulating around them, it will trigger a set of events to promote oxygen unloading, to help get this process going. Pull out more oxygen, let's get some more carbon dioxide in it as a result. Increased acidity will have the same effect. There's a very close relationship, again, between CO2 levels and acidity in the body, and higher temperatures. But one thing that I will point out in terms of hemoglobin and its affinity, the reason that carbon monoxide is so dangerous and how it can kill you, hemoglobin has more affinity for carbon monoxide compared to oxygen. Matter of fact, 240 times as much affinity. So it is, if you put carbon monoxide in your body, you are 240 times more likely that it's going to bond with, your hemoglobin is going to stick to those carbon monoxides as opposed to the oxygen. And as long as you increase that concentration, there's much more of affinity for that, and you could load up your hemoglobin with carbon monoxide as opposed to oxygen, and thus you're not delivering oxygen. In a matter of seconds, minutes, you asphyxiate because you don't get that oxygen where it needs to go. It's not getting carried like it should. Okay, let me see for a second what time we got. All right, let's take a little break, and then I'll try to go as far as I can after that. But I got to take about a 5-minute break here. So mostly I got to put this up before I forget. So you get a drink. I'm a little thirsty. It's Alzheimer's. Lupus is a bit more specific than that. I mean, you can rule out, you do a lot of tests and say that it's not this, and then if you have certain antibodies that are elevated, that's no conclusive proof, but it's good, it's the best they got, and they say by default we're assuming that you have lupus. It fits all the symptoms, that kind of thing. Rheumatoid factors? Rheumatoid factors, which I could either get rheumatoid arthritis or lupus. Oh. My dad had rheumatoid arthritis. My dad's got that bad too. That's why I'm scared though, because I like playing guitar so much. I'm afraid that one day my fingers are, because like right now, if I play for a long time, my fingers are like, they'll lock up like that, and then I can't move them, and I'll have to grab my hand and actually pull it and straighten out on my fingers. It scares me because I'm afraid that one day I won't be able to play anymore. There was like an autoimmune attack against them. Well, it just makes me kind of wonder if that's happening and you're getting this antibody response there, what's next? I mean, that's scary. I'm not trying to freak you out or nothing. But I mean, I'm sure you've already thought about it. So. Well, it's not his fault. I mean, okay, we just got a few more slides left here. Let's try to finish this out. I'll be very happy if I can finish respiratory today. So, am I on in there? Can you hear me? Okay. All right. Now, as far as your carbon dioxide that is traveling through the body, we talked about oxygen, talked about hemoglobin saturation, that kind of thing. Carbon dioxide is mostly transported as bicarb. You've probably heard this thrown around all the time, maybe if you work in healthcare, bicarbonate ion. A bicarbonate ion, if you care, is HCO3 negative. It's got a carbon, 3 oxygens, 1 hydrogen, all working together to form one functional unit. We call that a bicarbonate ion. Anyways, most of your carbon dioxide, when I say most, I'm about 60%, is actually transported as bicarb. Now, what that means to you is it means that as carbon dioxide is produced in cellular respiration, it gets converted, because think about it, if HCO3 with a negative sign is the symbol for carbonate, realize that within that you can pull out CO2, right? There's stuff left over, but at least you know that CO2 is within that. If you pull out CO2, where you get bicarbonate is from a reaction of water and carbon dioxide. When you put H2O and CO2 together, you get H2CO3, and that H2CO3 falls apart into the bicarbonate ion. Anyways, point being is it gets trapped up in that chemical reaction, and it gets transferred as an ion, as a floating bicarbonate ion that is not a gas. It's actually a dissolved ion like sodium would be, or potassium. And this is good because if 60% of our carbon dioxide was floating around as gas inside of our blood vessels, that would be a big problem. Okay, we don't want a whole bunch of gas floating around in our blood. So we have to sort of pull out some of that. We've got to figure out a way. It doesn't have a high affinity for hemoglobin, so it'll travel in the form of bicarbonate ion. You'll see that when you get up to the lungs, the bicarbonate switches back, and it gets extracted. The carbon dioxide gets pulled out of that carbonate ion, and then it turns into a gas again, and then we breathe it out. So as it is traveling through our body, it's not a gas. It's actually dissolved in bicarbonate. Okay. All right. So what you see is, like I say here, carbon dioxide, when it's produced, immediately reacts with water that's in the tissue. And you get water plus CO2, you get what's called H2CO3. Okay, and it makes sense, put all the letters together, H2CO3. H2CO3 is carbonic acid. It's the same type of acid that's in your pop. It's the acid that's always going to be present when you've carbonated something. When you've taken CO2 and pressurized it with water and forced them together, you're going to get a formation of H2CO3. It's carbonic acid. Now, the thing about carbonic acid is that it's very unstable, and immediately when it forms, it falls back apart. But instead of falling back apart when it's in a solution already, instead of that molecule falling back apart into this, CO2 and H2O, what it falls apart into is this. Okay? Hydrogen ions and bicarbonate ions. Now, this is important because, and we'll talk about acid bases a little bit later, but what makes acids acids and what acidosis is when you have too much of this guy right here in your body, hydrogen. Hydrogen makes something acidic. If there's too much hydrogen present, it's going to be too acidic. So you could see where I'm talking about the more CO2 that you have in your body that is being broken down. Elevated levels of CO2 produce carbonic acid, more carbonic acid. The more carbonic acid you get, the more free-floating hydrogens end up in the solution of the body floating around, so the higher the acid level is going to be. Okay, that's the relationship there. Now, you don't have to know all the chemical equations and all of that, but you do need to know, just bottom line, is when you have carbon dioxide, it can come together with water, and that carbonic acid is what forms. Okay, and that carbonic acid is what's going to produce this bicarb ion that's going to be floating around, and this hydrogen ion. You don't think you can remember that? Bicarbon hydrogen. Look up there. It's written right there. Okay? Just think about it. Just think out in terms of words. You don't have to worry about all the signs. Just remember, you breathe out carbon dioxide. That's what we're dealing with here. When carbon dioxide comes in contact with water, it can form an acidic solution. Okay? When it forms an acidic solution, what does that mean? That means you have put hydrogens floating around out there now. So you're going to by increasing the level of carbon dioxide in your body, you're going to increase the available free hydrogens floating around. That's the key. You can increase the acid level. Now, what comes about because of that breakdown, what also comes because of this production of hydrogen is this bicarb ion. But this is important. It has to happen because otherwise we wouldn't have that CO2 trapped up in there, and it's got to be mobile. We've got to be able to take it where we want to go. So one of the side effects of producing this CO2 and trapping it in bicarb is this leftover hydrogen that our body has to deal with. Okay? All right. There's an enzyme called carbonic anhydrase that will cause this to happen, what you see up here, in the erythrocyte, in the red blood cell. There's a little enzyme that will take this, and when this forms, cut this down, degrade it, and produce these things that you see right here, hydrogen and bicarb. Okay? Okay, now, this is favored at the tissue cells naturally because that's where more carbon dioxide is. So it all gets taken up and it forms this. Now, the reverse of this occurs in the lungs. What happens is you can take all those arrows and point them in the other direction when you get to the lungs because this now will combine with any free hydrogens that are around, form this will split apart into this, and you're back to CO2 gas again. The whole point is you start here at the tissues and you form this. Once you get to the lungs where it's cooler, it helps chemically, it go back that way, and you release that CO2 out of that bicarb is what happens. And then it can travel across those membranes in the cells, out into the alveoli, out into the atmosphere. Okay? Basically what we've done here is come up with a way to transport carbon dioxide in a non-gaseous way. That's the key to all of this. Okay. It says 30% of the carbon dioxide is bound to hemoglobin. Remember, what we're talking about here with this bicarb, that's 60% of the blood. Okay? What about the rest of it? There's still 40%. How do we carry the rest of the carbon dioxide? 30% of it is actually going to be stuck to hemoglobin, just like oxygen would be. Okay? Now, as far as the remaining 10%, it's going to be transported just as CO2 gas dissolved in the blood plasma. Okay? So we've got three big ways that we're transferring carbon dioxide. It's going to react with water, and it's going to produce bicarb ions when it does that. Those bicarb ions are going to float around until they get to the lungs. Then it's going to turn back into, it's going to get extracted out of that and turn back into CO2, and we're going to breathe it out. That's one way. That's 60% of the way that we're going to, 60% of the carbon dioxide transported, it happens in that manner. 30% of it is going to be just CO2 stuck onto a hemoglobin, and just like oxygen would be, and carried around. 10% of it is going to be just carbon dioxide all by itself floating out in our blood plasma somewhere, just getting swished away with the ride of the blood flow. That's it. We want to keep that number low. For oxygen, that number was only about 1.5%. Okay, we want to make sure we keep that number low. We don't want a lot of free gases just floating around in our blood. We want it anchored somewhere. Okay. Now, I talk about the chloride shift. Let me point out something here on this. Memorize all of that. Think I'm kidding? Huh? We'll see. No, I'm kidding. You don't have to memorize that. But I want to show you something. Here's a tissue cell. Oops. Was a tissue cell. Here's a tissue cell. We know that O2 is coming into a tissue cell. CO2 is leaving a tissue cell. All right. That CO2 that comes into the bloodstream, where does it go? I told you that some of it, about 10% of it anyways, is going to stop right here and just stay dissolved out here in this blood plasma. These are erythrocytes. This is your blood vessel. All the yellow is your blood plasma. Okay? Some of it just stays dissolved. Some of it comes in, as you can see over here, actually enters the erythrocyte. Now, when it enters the erythrocyte, what it can do is the hemoglobin, HB stands for hemoglobin, it just dumped off its oxygen, so it's free. So there's some leftover hemoglobin now that could bond to anything if it needs to. So what happens is some of that hemoglobin bonds with the carbon dioxide that comes in, and it carries carbon dioxide now. It can do that. We said about 30% of the carbon dioxide is transported via this means. Okay? Now, so we've got 10% of it just dissolved out here floating around, 30% of it getting stuck onto this hemoglobin that just dumped off its oxygen. What is all this crap down here? Okay? Carbon dioxide can also react inside this erythrocyte, where this is going to happen, but it can react with the water, like we said a second ago. And when it does, with the presence of carbonic anhydrase, the enzyme necessary to make this happen, we can produce, as we said before, these two ions, hydrogen and bicarb. Now, don't worry about the hydrogen right now. We'll deal with that later. There's a lot of things our body can do to absorb that. You can see one there. Hemoglobin can actually suck up some hydrogen and help pull it out and make it not so dangerous, but let's just not worry about that right now. Let's look at the bicarb because that's what's important. Okay? You guys, you wouldn't make it. If you're panicking about this, you wouldn't make it in my chemistry class, I'm telling you. Okay, so what happens here is something called a chloride shift. You can't just start pumping stuff out and changing the osmotic gradient. If you want to maintain homeostasis and you want to start cranking stuff out and putting it out here, you're going to have to pull something back in as a result of that, okay, to keep things balanced. This is the chloride shift that I mentioned on the previous slide. What you'll see is, okay, rewind. Some carbon dioxide stays dissolved. Some of it goes in here. So the one that goes in here, some of it can stick to hemoglobin and go for a ride. The rest of it will react with water inside this cell, produce bicarb. When bicarb is produced, what happens is it gets transported outside of the cell. It gets dumped out here into the plasma. That's what this is a protein channel right here. It kind of flips around. Notice what comes out, what goes in to replace that in terms to maintain an osmotic gradient. So if bicarb gets shifted out, chloride gets shifted in. That's called the chloride shift. Okay? That's what this is. Now, what happens when we get to the lungs now? What's wrong? To maintain osmotic gradients. For example, if you kept taking bicarb out of this cell right here, and you never put anything back to replace it, what would happen to the concentration of particles in the plasma? They would continue to forever increase. What happens if they continue to increase? Water then would start leaving the cells, right? If there were more solutes out here, more things dissolved out in the plasma, whatever water you have in here could start leaving based upon osmosis, like we talked about already. So you have to maintain these osmotic gradients. So if you're going to pull something out, you got to be sure to put something in so you don't affect water movement or anything else. All right. Now what happens now when we get to the alveolus? We transport all this stuff up there. What we have now is cells that are low in terms of oxygen. They dumped it all off at the tissue cells. High in terms of carbon dioxide content, and also in blood plasma. We've got some bicarb floating around in there. We've got to make our switch. We've got to dump off carbon dioxide and increase our O2 levels. So how can we do that? Well, you'll notice that, first of all, any hemoglobin, any carbon dioxide that was bonded to hemoglobin falls off because of the temperature change, and it just gets taken, goes right across the membrane into the alveolus and out. Okay? That frees up a hemoglobin. So what can that hemoglobin do? Bond with oxygen that's diffusing in. Okay? So there's one thing that can happen. We know that this is mostly how oxygen is carried, right? Now, at the same time, what happens in terms of the bicarb that was floating? When we get to this area, any bicarb that's out here floating around, okay? First of all, before we get there, if you look at the dissolved, I had some just CO2 that was floating around out there. That's just out there. Its arrow is right here. It goes straight across. It doesn't have to have anything special happen to it. It's already there. It's just going to diffuse across. The stuff that was stuck to hemoglobin is going to fall off to free up that hemoglobin to pick up oxygen. Now, when it falls off, it's going to come over here and leave and go up. Now, that leaves one more thing we have to deal with, and that was anything to do with bicarb. Okay? Now, what happens is this bicarb comes in now. You've got the chloride shift in reverse is what you have now. This shifts back in. Chloride has to come back out to balance it. When this comes back in, notice that, like for example, you've got hydrogens present. One place it was present was because it hooked up over here and carried it for this purpose, kind of in its back pocket, holding it until we got over here. We've got hydrogen now that can bond with the bicarbonate as it comes in, and then it pushes the reaction back to the left. And it goes back the other way, the opposite direction which it normally occurs. You get a production of CO2 gas when that happens. That gas leaves, it comes out. Okay, it leaves the cell, comes out, crosses over into the alveoli, becomes part of the CO2 that we breathe out. So there's a lot of things that are happening. Okay. make sure you can get a general idea as how we are transporting the different ways by which we transport this oxygen and CO2. Okay, how much of it in each case is transported? 60, 40, 30, or 60, 30, 10, whatever. Okay. Now, as far as respiratory states, obviously we can describe different respiratory states based upon these abnormal blood gas levels. Do you have too much CO2? Do you have not enough oxygen? What have you? There are 4 general categories of hypoxias. I don't mention everything. Your book will talk about more, probably for the homework assignment, probably even for the test and the study guide. You may have to look up a couple more. Okay? But here I'll just mention a couple. Hypoxia in general means too low of O2. You don't have enough oxygen in the body. Now, that doesn't define a causative reason. It doesn't tell you why. All it is states the obvious, states the condition. There's a hypoxic condition. Too little oxygen, insufficient oxygen. There can be hypoxic hypoxia. That's not redundant. Low partial pressure in the arterial blood. All that means is the total count, the total partial pressure in the arterial blood is lower than it should be. You don't have as much oxygen in there as you should. That's called hypoxic hypoxia. There's also something called anemic hypoxia. Basically, this gives you the impression that there's insufficient oxygen delivery, but it's not because there's not enough oxygen there. Instead, anemic has to do with how well the blood can carry the oxygen that is there. There's reduced oxygen carrying capacity in the blood. You could have iron-induced anemia, right? If you do not have enough iron in your diet, you do not form adequate hemoglobin. If you do not form adequate hemoglobin, you cannot carry oxygen effectively as you should be able to, in which case you're going to have anemic hypoxia. Okay? You can look up some more. Hyperoxia is too high, above normal arterial pressure of oxygen. Things aren't kept in check, that kind of thing. Hypercapnia, if you've taken micro, you learn about capnophiles. Capnophiles are things that love to grow in CO2, okay, carbon dioxide environments. So hypercapnia is an excess of carbon dioxide in the blood caused by hypoventilation. You're not breathing enough, so you're not ridding enough carbon dioxide away. Acid levels can start to build up and all that kind of stuff. Hypocapnia is below normal levels of CO2 in the blood. Due to hyperventilation. If you hyperventilate, the biggest risk that you run is blowing out too much CO2 and disturbing the levels that way. You can have hypocapnia if that's the case. Hypernia is an increased need for oxygen delivery and carbon dioxide elimination during exercise, so it's specific to exercise. All right. Out of all of that, what you need to know is that we have centers in our brain that control breathing. We have inspiratory and expiratory pathways that we deal with here. The medulla is where most of it's going to be located, as you can see right here, medulla in the pons, this area of the brainstem. It is a very basic thing that we do, so it's very bottom line survival kind of thing. So it's autonomic. It's controlled by the brainstem. We don't put a lot of thought into it. You can read through this and see that, for example, the apneustic center is in the pons prevents the inspiratory neurons from being switched off. You have a constant input of inspiration, basically, of contraction of those things to cause that volume to change, to cause the pressure to decrease, cause the air to come in. That's constantly turned on. There has to be something in there, this center like here, it's preventing the inspiratory neurons from being switched off. So what you've got to do is have another thing that can allow them to be switched off and have a checks and balances type of system. Okay, that can get all screwed up. When it does, you've heard of like sleep apnea and that kind of thing. This is a neural type of situation where those pathways aren't in sync with one another, so they don't cycle like they're supposed to. Okay. So it says the signals travel from the receptors to the lungs. There's stretch receptors in the lungs. Those are the signals I'm talking about. As they stretch, there's mechanoreceptors that start a nervous impulse. So stretch receptors in the lungs, they activate. They travel to the lungs. They travel from the lungs. When that pathway gets here, it goes back towards the lungs by afferent neurons. Inhibiting the respiratory center, you inhibit that center, causing inspiration to stop. Realize that whenever you start to, when you change this and cause inspiration, as you are inspiring, there has to be a point when your brain tells you to stop and start to expire. That's what we're talking about here. As those stretch receptors reach a threshold, they send a message. It'll go to your brain, and it'll shut off that system, and then it'll kick in the expiratory system. And then it goes back down. So if those stretch receptors go bad, that's going to screw some things up too. Okay. Okay. You've got carotid bodies. You've got aortic bodies. These little places right here that are specialized receptors that are hooked into the nervous system that detect this pressure. They can detect not just pressure, if they're baroreceptors. If they're chemoreceptors, they detect changes in chemicals present, like CO2 especially. CO2 and hydrogen are the two biggest in terms of what's monitored during respiration. Okay, a decrease. You can increase the respiratory rate if you get a decrease in oxygen. Naturally, the body would want to increase your respiratory rate if you decrease your oxygen levels. If you increase carbon dioxide levels in your body is going to want to start breathing more to rid those. Or an increase in hydrogen ions. Why would you get an increase in hydrogen ions? Because you get an increase in carbon dioxide. The two are related. I say here, carbon dioxide generated hydrogen ions in the brain are normally the primary regulators of ventilation. It's not CO2 necessarily that your brain monitors, it's the hydrogen levels that often are increased as a result of CO2. So that's the biggest thing you're going to get. You ever think about giving somebody CPR? You're not blowing oxygen into their body. Okay? We don't do that. We're blowing carbon dioxide, and what we do is we can blow more carbon dioxide into their body, temporarily increase maybe these levels, increase the amount of CO2 for these receptors to pick up, which would increase ventilation, or we can increase also the amount of acids that's there that the brain can pick up that would want to naturally jumpstart and increase ventilation. That's the whole point behind it. It doesn't always work, right? But the whole point is to bombard with more CO2 and localize, at least in terms of more more hydrogen, in order to sort of jumpstart these levels, especially with these chemoreceptors in these bodies right here and the brain, to sort of turn this center back on and to jumpstart it and to get it increasing respiration. Okay, let's see. Oh, this is interesting. I want to point this out. Obviously, acid-base balance has become very important. We have to use our respiratory system to keep our carbon dioxide levels appropriate so that we don't induce acidosis in the body. And we'll talk about that more in a later chapter. But when you do get a buildup of hydrogen in the blood, you're going to increase your respiratory rate. But as a result, it says hydrogens are removed from the blood as needed, making adjustments needed to control blood pH. Your body will increase that rate to pull out those hydrogens. pH has to do with acidity. Okay, so controlling pH means you're controlling the hydrogens there, getting rid of them to put the pH back where it needs to be. But I mentioned here, though, that when I said that your brain mostly looks at the hydrogen ions present, this is mostly the reason that you can't hold your breath. You can't, like, for example, kill yourself by holding your breath, or you can't just indefinitely hold your breath. Okay. It's very powerful influence. You can't force yourself to hold your breath long. What will happen is the second that you're doing it yourself, unless someone else, is involved with the process. But if you're just trying to hold your breath, you can't force yourself to do that. What will happen is, unless you're physically preventing airflow, I'm talking about just staying there and halting your respiratory activity. Because what will happen is the signal, that buildup of, it doesn't take very long either, that buildup of hydrogen in the brain is going to want to increase and override, and it's so strong it's going to kick in your respiratory response whether you want it to or not. It's not conscious, it's not voluntary, it's going to happen. Now, of course, if you physically prevent airflow, that's a whole different situation. I mean, I'm talking about just sitting here consciously breathing. You can't just decide to stop breathing and die. We can't do that. All right. As far as how exercise cellularly and chemically causes you to increase ventilation, you could say generic things like, oh, well, you're using more oxygen and all that kind of stuff. But as far as the mechanisms by which that works, it's actually not that well understood in terms of how you can induce these changes and increase breathing rate just from exercise. So I find that kind of odd. And obviously you can alter ventilation by weird things. You can cease ventilating by sneezing or coughing. You can't breathe while you sneeze, and you can't breathe while you cough. That's completely counterintuitive to the point. The point is to clear the respiratory tract. So obviously you're not going to allow something back in as you are coughing or sneezing. And then if you inhale a noxious substance, like for example, if you take a big whiff of ammonia or something like that, it'll literally take your breath away. You will stop breathing for a moment. It's a natural response to keep that stuff from going into your lungs. It's a programmed response to protect you. So that would cease ventilation. Okay, as far as apnea goes, we've got an interruption of ventilation. Some kind of pattern is not right. You've got irregular, if you know anybody that has this, or at least, if I've read case studies or whatever, you know that it's the cycle of breathing, inhalation and exhalation, that is the problem with this person. And if it's not controlled, obviously, you could have abnormal buildups of CO2. You could, worst case, death could result as from all of this. This is especially going to happen during paradoxical sleep because for some reason during that stage of sleep, we are less sensitive. Our partial pressure of carbon dioxide sensors are less sensitive during that area, so they don't register as well as they should. So obviously that second bullet is true. You should know that. But I will mention sudden infant death syndrome here with regard to sleep problems. Now, they don't know for sure what causes this. I haven't researched it for a couple semesters. I mean, I was looking some stuff up about a year ago, and I haven't found any new developments at that time. I don't know what's out there since in the past year or so. But what they think the cause might be, you think about, laying them on their back and their stomach, and then that'll change, and then they say lay them on their stomach, then they say backwards, whatever. I mean, you can't keep up with it all. But what seems to be is something neural in that mechanism we talked about, like with the brainstem and the controlling of those centers. There's probably things you can do to decrease the risk, but there's really probably nothing that you can do to eliminate the problem. Possible immaturity of respiratory control mechanisms. Actually, literally forgets to breathe. Those cycles don't work like they should. There's some sort of malformation. It's to the point where you can't really trace it, though, and you can't really see because they don't know what they're looking for at this point. But it's probably something related to that. Possible risk factors. Notice it doesn't say causes. It just means risk factors. Maybe sleeping position. There's a lot of research out there that certainly suggests that. But again, that's correlational research. You've got to take it within context. There's all kinds of things I hope you guys, if you ever read this medical types of research, that you realize. I mean, I like using the example of if you eat ice cream, you're more likely to drown. That's true. If you eat ice cream, you are more likely to drown. Why? Now the thing is, you would assume it's because there's some brilliant reason. But think about it, because these are the kind of claims, this is an exaggeration, but when you watch the news, these are the kind of research reports you're going to be hearing, and we hear all the time, and we're just thinking, oh my God, I heard on the news the other day that if I eat cauliflower on Thursdays, I'm going to die of cancer. And people start buying into this crap, but you need to read the study and make sure you see it in context. I want to reason through this with you. I want you to answer my question. Why are you more likely to drown if you eat ice cream? It has something to do with the temperature. Now get creative. Get creative. I didn't say just die. Did I say die? Drown. That's right. Think about that. I didn't say you're more likely to die necessarily. You're more likely to drown, huh? Ice cream melts? You think that's the melted ice cream is going to make you drown? Maybe. Well, how do you drown if you're not in water? Stick with your line of thought, though. You're getting closer. Well, pretty much you got liquid inside no matter what. Everything turns to mush. You don't think that, you think the temperature of ice cream is enough to cool your internal body temperature? No. Easy. This has nothing to do with that. I want you to think through this. There's a point to this because I want you to critically evaluate all these claims that are made, especially since you people are in the field. I want you to think about all of this. And I want you to see that there are connections that you can make and that researchers will make because they get paid to make these connections. And I want you to realize the difference between truly what the data says versus what anybody can say the data actually says. Okay? When you eat ice cream, do you eat more ice cream in the winter or the summer? When you're in the summer and the winter, which do you spend more time in the water? In the summer. So do you think that the risk of drowning increases the more you're in the water? Okay, so you're in the water more in the summer, which happens to be when you're eating more ice cream. So you could actually say, and you wouldn't be lying, that according to the data, ice cream, there's a direct correlation between the consumption of ice cream and the incidence of drowning. So you're more likely to drown if you eat ice cream. You think. I agree. However, you got to be careful because this crap happens all the time. It's called correlational research. It's like this whole broccoli and cancer stuff that they read. Huh? What?
Don't eat ice cream in the summer, eat it in the winter.
I guess. And this is what do you understand my point of what I'm saying here? You got to critically evaluate some of these claims that are made and take them within context. You can't just say because the news said it and these guys, researchers said it, that's the difference between, just taking it and believing it because someone said so based upon the title versus looking at the work that they've actually done and see if their claims are true. Like I said, you could claim that this food causes this. Well, that may be true if you based upon the sample that they had, the people that they were dealing with, what it is they were actually measuring. You'll find that you can pretty much twist anything you want into saying what it is you want. And when special interest groups are paying for your research and when certain agencies are paying for your research, they want them to say certain things. Okay, like all those tobacco companies that have people researching saying that there is no direct link and there is no proof because they have researchers showing and setting up scenarios where that is true based upon their research. So you just got to think things through and you got to realize that a lot of correlations are drawn where they actually might not exist. The last thing here, just another slide. I just liked them, so I tried to pick as many as I could. I got all these from, I think it was Yale Medical School, has a website with a bunch of cardiothoracic imaging. So I got a link to it there. This is pulmonary edema, normal situations. You can see with pulmonary edema especially, remember what pulmonary edema is, you sort of get a backup in the blood supply to the lungs, so it can force back on the heart, and the heart can increase in size a little bit. You get some fluid deposit here. You see the whole cardiac border enlarges. You get more fluid up in this region and all that kind of stuff. So I just thought it was cool. So, all right. That's it.